Severe internal sepsis creates a chaotic biological environment where rapid tissue degradation outpaces the body's compensatory mechanisms. Looking at this clinical timeline, starting at day 0, a 62-year-old male staged at PT3N1C underwent a low anterior resection with total mesorectal excision. Because of the aggressive tumor biology, he received total neoadjuvant therapy prior to surgery. We advanced the clinical timeline to post-op day 5. 2 critical metrics suddenly spike. The patient develops tachycardia and a fever. There is a strict rule following a low colorectal anastomosis. Any fever is an active leak until definitively proven otherwise. A common professional pitfall is dismissing these specific day 5 symptoms as routine atelectasis or postoperative ileus. In this specific surgical context, treating a fever as benign wastes hours. The surgical team must immediately shift from routine recovery to acute crisis management. The immediate diagnostic requirement upon suspecting this leak is a CT of the abdomen and pelvis using rectal contrast. This schematic of the lower intestinal tract shows what the imaging reveals: contrast fluid actively leaking outside the luminal boundary and pooling into the surrounding pelvic space. This behavior proves a catastrophic anatomical failure. The patient is rapidly developing fecal peritonitis inside the pelvic cavity. This requires an emergent surgical response. The patient must return to the operating theater for a Hartmann's procedure to control the abdominal sepsis. The surgeon now faces 2 simultaneous objectives: executing a precise technical salvage of the disrupted anatomy and preserving a forward-looking oncological strategy. Surviving the acute leak is only the first hurdle. The precise execution of this salvage operation dictates whether the patient will have any viable oncological options in the future. To perform the Hartmann's procedure and create a functional stoma, we have to look at the vascular constraints of the abdomen. Looking at this map of the abdominal vascular tree, notice the inferior mesenteric artery fades out entirely. It was subjected to high ligation and is permanently gone, meaning standard forward colonic perfusion is permanently compromised. The physiological workaround relies on retrograde blood flow from the superior mesenteric artery. This blood flow travels across the middle colic artery, routing through the marginal artery of Drummond, the final vascular bridge delivering perfusion to the remaining colon. Failing to verify the viability of this retrograde vascular loop before maturing the stoma guarantees tissue necrosis, leading to a fatal secondary complication. Once the upper anatomy is secured, the surgical descent begins, moving down into the highly inflamed hostile pelvic cavity to clear the peritonitis. Acute inflammation and sepsis obscure normal tissue planes, making the identification of baseline anatomical structures extremely difficult. This schematic of the pelvic cavity highlights the first mandatory landmark, the ureters, which must be protected. The autonomic and hypogastric nerves form the second danger zone. Injuring these specific nerve bundles during a hurried salvage inflicts permanent genitourinary dysfunction. The necessity of speed in achieving sepsis control cannot justify the destruction of the ureters or autonomic nerves. Preserving these structures under pressure separates a panicked response from masterful surgical execution. Focus then shifts entirely to the newly closed distal rectal stump, which is left behind deep in the pelvis after the stoma is created. A common misconception is that an aggressive abdominal washout from above achieves complete source control. This cross-sectional view of the closed distal rectal stump dismantles that misconception. Luminal contents remain trapped inside the cavity below the new staple line. To achieve true source control, an instrument must be inserted transanally to access this isolated distal cavity. High-volume fluid is then introduced directly into the stump from below. This flushing mechanic actively dilutes and removes residual fecal matter and bacterial colonies embedded in the mucosal folds. The newly placed staple line at the top of the stump is acutely structurally vulnerable. Any trapped bacteria left behind will rapidly produce gas, continuously increasing the internal pressure against that fresh closure. The transanal washout is the definitive mechanical intervention. Without it, bacterial gas will inevitably cause a stump blowout, instantly recontaminating the pelvis and rendering the abdominal salvage useless. The acute surgical crisis in the OR is over. The clinical timeline now moves forward to the finalized postoperative pathology report. The staging is confirmed as PT3N1C. This stylized histological scale illustrates the pathologist's critical metric, The circumferential resection margin measures exactly 0.5 millimeters. Clinically, any margin under 1.0 millimeter is officially a positive margin. Physically, this means the surgeon unequivocally left microscopic tumor cells behind on the pelvic sidewall. The operational standard is an R0 resection, complete tumor removal with negative margins. The initial operation failed to achieve this. Despite surviving the severe surgical catastrophe, the patient now harbors residual, biologically aggressive cancer. This immediately elevates their risk profile for a severe local recurrence. The multidisciplinary team now faces a high-stakes dilemma regarding how to treat the remaining tumor. The crucial variable limiting their options is that the patient already received extensive total neoadjuvant therapy prior to the first surgery. This logic flowchart outlines the situation. With previous therapies exhausted, secondary pathways are strictly limited. The first pathway involves waiting for the patient to regain enough physiological fitness to attempt a highly morbid, radical re-resection. The alternative pathway concedes the impossibility of a surgical cure, restricting the patient to palliative intent therapy. The biological aggressiveness of the surviving tumor will dictate which of these difficult paths the team must choose. Returning to the surgical timeline, there is one final, unyielding post-operative rule regarding the salvaged Hartmann stoma. Suggesting a stoma reversal earlier than 3 to 6 months after an episode of fecal peritonitis is a fatal error in clinical judgment. Consultant-level mastery requires absolute technical precision in the moment, but it also demands long-term